So, we're going to talk about bereavement and the psychology of that. It's not going to be rocket science, and I don't want it to sound like I'm teaching my grandmother to suck eggs, but sometimes I think it's really helpful to go back to the basics and think about, okay, what are we doing and why are we doing it and what are the steps as we go. So do feel free to ask questions as we go through, and if it's going really badly, I have got Cadbury's chocolate eclairs to bribe you with, okay? So
Good time to arrive.
Yes, spot on timing. I also want to try and make it a little bit more real rather than abstract, so I have created a couple of a patient and his wife. These are not real people, they're just a creation, so we can refer back to them and follow their progress a little bit. So we've got Peter. He's 67, he was diagnosed with cancer 2 years ago. We're not going to go into what type because that's not too relevant to what we're talking about. It doesn't matter what sort of terminal illness someone has, most of this applies. 4 weeks ago, he was told that there's no more treatment other than palliative. So he's only quite recently heard that news. He's also been told that he probably has months rather than years. He retired a year ago, and he had great plans for his retirement. He's not really got into the swing of it yet. He was just getting used to being at home, but he had lots of things he wanted to do. He loves DIY, gardening, socialising. He's the sort of person who never had a day off work sick. That's just who he was. Didn't really want to retire, but he had to. Married to Sue for 42 years. They've got 2 children, April and Tom, and 3 grandchildren, 4, 12 and 14. And there's Sue, who is his wife. A bit about her, she's had chronic back pain for 20 years. She doesn't drive, but she enjoys socialising in the little village where they live. She's got a good network of friends, and she's had a couple of episodes of depression in the past. So that's who we're going to be following through. We're talking about bereavement, and again, this is something you'll know. It's not just post-death. Bereavement starts long before that. So can we just have a quick think about what sort of losses this couple might be experiencing? Apart from the obvious, what other things do we need to take into account when we're thinking about what Peter and Sue are dealing with right now? Roles, so you mentioned roles, and this seems to come up quite a lot with people I work for or work with. They had a specific role within the family, and now that's gone. Maybe because emotionally they can't do it, or actually physically they can no longer do it. So Peter was always the one that did the DIY around the house. He did the gardening, and now he can't. So the garden's looking messy. Sue's not really into that, so she's not doing it. He feels bad that he's not doing the things around the house that he used to do. He feels bad that Sue's having to try and cope on her own. So there's this big shift in who did what in this relationship. Social life, Peter stopped going out as much as he used to. He used to enjoy going down the pub with his friends. Because he's no longer doing that, and because some of his friends don't know how to talk to him, he's not getting that interaction anymore. And meaning, so yeah, what does his life mean now? He was a husband, he was a grandfather, he was a provider, he was going to do all these things with his wife. None of that's going to happen now. So who is he? And what is the point of his life? It might not be a long one, but he's feeling that actually there's no point to that bit that's left now anyway. And Sue, yep, she had retirement plans as well, all these things she hoped to do, and she may still be able to do them, but she won't have Peter there to do them with. Work for Sue was a really big thing. That was a lot of her socialising. It gave her, a sense of routine, of achievement of purpose. And she's given that up, and she feels it was right she gave it up, and for the right reasons. But still, it's a loss in her life right now. Social life again, ability to travel. She doesn't drive. Peter was always the one that did the driving. And there's a lot of anxiety in there. So finances, living alone. She's never lived alone. How will she cope with that? And managing household tasks, as we've talked about. So all this is going on long before an actual death. Who's familiar with Kubler-Ross? Yeah, it's quite a well-known model. So this is a stages of grief model. And this applies again to pre-death bereavement and post-death bereavement. So I thought we'd spend a bit of time going through it. It's not the be-all and end-all in terms of model of grief, models of grief, and we'll talk a little bit about why that is. But the idea is that there are these different stages. So you've got denial, you've got your anger, bargaining, depression, and acceptance. Now, that's not to say, though, that people go through these stages nicely, one at a time, move on to the next, to the next, to the next, and they're all little discrete phases. And that's one of the criticisms of this model, is that it seems to imply that's what happens. You trundle through them, and there's lots of TV programs that do little skits on this. It's like, oh, I'm in the anger phase, when am I going to move on? It doesn't really work like that. People will go backwards and forwards. So not only is it but people may spend a long time here and then move here and then go back. And yeah. Acceptance, I'm not hearing it from here, but for some people it's synonymous with giving up. They hear acceptance and think, well, what I have to accept that I'm going to die, and I kind of give up. I've heard that from a couple of patients, maybe not all. I think acceptance is becoming more understood, but it's like the Serenity Prayer. I misquote it all the time, but it's the wisdom to know what I can change, and to understand what I can't change, but to accept that there is this thing, I cannot change it, but actually there are all these things that I still can change. So the meaning in life, if it's right for them, talking with family, making plans, all of those things I can change. So you're not fighting against it, you're not bargaining, you're not pretending it's not happening, you're not stuck and not moving. You've said, okay, yeah, it's there, but actually there's all of this still here as well, and I can do something with that. And it's not this nirvana that people reach and everything's lovely and wonderful. It is a backwards and forwards thing again. One day someone might think, yeah, I've accepted this. Next day, totally different. And that's normal. Okay. Denial. Denial often prevents that forward movement. If you're not engaging with what's going on, you can't think, you can't plan, you can't make those decisions. So the big barrier there is it prevents you from moving forward. Anger typically is displaced. So it's often projected to family, to children, to healthcare professionals, and it keeps those people then at a distance when perhaps the patient most needs them close by. Anger itself can be incredibly destructive as well, because what do you do when you're angry at yourself? You can't get away from that person, you can't escape that. Bargaining can become rigid. So if I do this, I'll be okay. Therefore, I must always do this, because if I don't do this, I won't be okay. So I must always take this medication, or I must never take that medication, or if I allow this to happen, this will happen. If I go into the hospice, I will die next week. There can be a lot of rules that become quite rigid. And again, it prevents people thinking through what is best for them in that moment, because what is best for them changes as they progress. And depression, again, is that idea of not living, not having the quality of life that you could, though it's vastly reduced, but not having the quality of life that you could because you feel so overwhelmed and all the words that we might use to describe depression. You're in that state where there's no motivation, you feel worn down by it all. So there are things that physically and emotionally you could still do, but the depression is preventing you. And it's important to know that not only are these unhelpful in themselves, but they are effortful. It is hard work being angry. It's hard work denying what's going on. It's really hard work. And yes, it's emotional work, but it can be physically fatiguing as well. And it's distressing, particularly to those around you, around the patient perhaps. So the wife whose husband won't talk about the finances because he's not going to die. So then she's worried about the finances and doesn't know what to do and can't do anything because he's in charge of them and he won't talk about them because he's not going to die, and so on and so forth. So we said the Kubler-Ross model it's useful to have in your mind, but this is another way of looking at where people are along the process. So actually it's up and down, it's up and down, it's up and down, it's up and down. This is more a model for post-death bereavement, because things do gradually get better as you progress. But one day to the next, it's all over the shop. And the other thing is that point 2 there, again, normalising that can be helpful. That actually it's incredibly normal to be experiencing these things, and that they're not just going to go away. So many people say, oh gosh, it's been however long, I should be over this by now. And being able to say, well, actually, should you? Why should you? What's that about? And just having that conversation. Yes, there maybe comes a point where you think, okay, yeah, there's something else going on here. 9 times out of 10, though, it's maybe a month down the line, all their friends have moved on and they're saying, I should stop going on about this, I should be okay, I should be getting on with it. And you're just saying, well, hang on a second. Actually, maybe what you're experiencing is normal. And I think that's what a lot of the psychological work with grief is about saying, well, don't be too hard on yourself. Let's just sit back and have a think about this. Let's talk about this. It's not a pathology. We don't have to jump straight into, oh gosh, this is a big problem. If they do have something that's kind of scratching away at the back, and maybe they don't want to mention it to anyone else because they worry what they might think of them, giving them that opportunity, explicitly inviting that, can be hugely, hugely useful. And a lot of times, or not a lot of times, occasionally we'll have people come in who've been bereaved who are cross at how things went. And maybe they're cross at the health service or some part of their care. Maybe that's justified, maybe it's about something else. But giving them that opportunity to say, actually, I feel really angry about this, I'm really upset about that. Just giving them that opportunity to talk it through can do the world of good. Maybe things need to go further, maybe they don't. The NHS, although I have left them behind again and come back out, but I think they had the duty of candour was kind of being mentioned a lot as I was leaving. So this idea that rather than saying, well, that's not how it was, and I'm sure the doctors did everything that they could, maybe just saying, I'm really sorry that was your experience, and actually, do you want to talk more about that? It's not about saying, yes, it was wrong, and those people did a bad job, but when someone's in that state they don't want to hear, well, actually, you've got it wrong. That's not what they want to hear in that moment. It can escalate things. So just saying, do you know what, that sounds really bad. Let's talk about that. Again, it may not go anywhere. It may not need to. And that could diffuse it all and help that person talk through the anger or the distress that they're feeling. What can be useful sometimes is to state a boundary quite early on. And that sounds harsh, but if someone comes in and says, I really want to catch up with you today, to let you know so we know what we're working with, we've got X amount of time. But what we'll do is we'll book another appointment in. Now, you may still end up going over that a little bit, but it can be it depends how you say it, but it can be quite reassuring to someone to know how long they've got. Because some people won't want to take up your time, so won't talk for fear that they're already taking too long. Other people will get started, and actually in the back of their mind they're thinking, how long can I carry on for? So to have a boundary allows them to know, okay, I can say this much, and okay, right, so I can come back in that amount of time. So it can be really useful. Sometimes you have to go with it, and you're going to give them that time. Sometimes if they come in, you say, we've got 10 minutes, but if we need longer, we will book another time. It can also help in that if people are feeling quite overwhelmed, to go on and on and on isn't always useful, and they kind of get caught up in going around and around, and to be able to bring it to a close and to feel that, well, I haven't gone through everything, but again, I know when I can come back and go through more. It depends on the situation. So this comes from NICE, and it's just a really handy way of thinking, okay, what tier do we need to be looking at for this person? So tier 1 is your normal everyday stuff that you might do in your practice, just in those little conversations that you're able to have in your 5-10 minutes. Tier 2 is when somebody needs maybe a little bit more. They don't need a major intervention, nothing's massively wrong, but perhaps they'll benefit from talking to someone who's not family, who's not a friend, and can give them that little bit more time. Tier 3 is when there's something not quite working here, and they maybe need a slightly more intensive intervention. And tier 4 is when there's a real problem. I think the key things that I'd want people to take away or to think about are, often people have a lot of psychological skills that they don't realise, so it's having the confidence to use those skills in those short interactions that they might have with patients. And in those short interactions, it's about really listening to the patient, listening to what they're telling you, but also perhaps having in mind some of the models that we covered tonight. So just basic ideas of the kind of things to look out for, where things might be going a little bit wrong and more support might be needed, and just keeping that in the back of the mind, asking those open questions, getting the information and offering support, and then following up, keeping the door open, and also having an awareness of what support services are out there that they can refer people onto as and when that feels appropriate.